Yeah, I was like, trying to open the door. I didn't notice there was anything there. I'm like staring on.
Get that.
I'm like,
That was my whole morning where I was like, I kept having to look at my watch. I was like, is it Monday or is it Sunday? Like, I was like driving to work. I was like, I got ready, but is it really like, am I supposed to be at work today? Yeah, it's okay, man. I totally get it.
yeah. So I was at the hospital. I sat and went to the freaking house. I was like, it already happened. We're like, no, it didn't. I'm like, Dad, you're making me and my throw my you're throwing my day off because he's asking me. He's still there. I had to go for a photo because I wanted to. But after I started this season.
Oh, I have a freaking meeting today. I hate that, man.
Recording in progress.
So here, so keep it here.
Oh, you're there. My bad.
All right, sorry guys. All right, everybody get signed in. Yeah, we're gonna do the chapter 16 review. Kahoot. This is gonna be echoey for a little while, so I'm just gonna have to deal All right, we're gonna play the game. We're gonna do the robot chase game. Back. I already Okay, everybody ready? Remember, you can always join in. We started with chapter 16, Kahoot thing. Then we'll get into chapter 17 lecture, but chapter 17 relies on a lot of knowledge from the chapter 6. Maybe a number of all right, where do all lymphocytes begin development? We're doing it this way. All right, all lymphocytes are going to start their development in the bone marrow. Remember, that's where all blood cells come from, not just the white blood cells, but also that's going to be including your red blood cells too, right? But yeah, they'll start there. That whole process is called hematopoiesis. All right, next question. During maturation, lymphocytes beat out anti-self clones and will only allow appropriate clones to proliferate. What's the term for this? So weeding out the anti-self and only propagating the correct one. The anti-fidget spinner, for example. Where is, oh, here it is. Ready. So this is called clonal selection. Remember the process where we're weeding out the anti-self lymphocytes, that specifically is called clonal deletion. But that whole process of going through clonal deletion and then propagating your clone of interest, that is clonal selection.
So passive, but it's taking time.
All right, what is the term for something that is too small to elicit a proper antibody response? All right, so this is hapten. That's just one of those vocab term we have for this chapter. Haptens are the things that are too small. Toxins can fall into that category, but other things can be haptens, not just toxins. So on which cells are MHC2 markers presented? All right, so MHC2 markers are the markers that present stuff from outside of the cell. Remember, MHC1 presents stuff from inside of the cell. MHC2 presents stuff from outside of the cell. So the only ones that present stuff from outside of the cell are going to be the antigen presenting cells. That includes B cells, but it's not just B cells. So that's why B cells isn't really like the only right answer, but it is still one of the right answers. So some of you got the B cell right, but not the APCs. B cell is an APC, so. All right, what do cytotoxic T cells do? Alrighty, so cytotoxic T cells are going to go around killing infected self cells. So our cytotoxic T cells are our CD8 positive T cells. Yeah, I don't know, that's what they do. They make perforins and granzymes, which is probably the next question. Maybe not. Which cells are necessary to activate B cells to become plasma cells? So they can't just do it on their own, even if they pick up their antigen from the lymph and find it and become an antigen presenting cell, they still need some kind of signal. What kind of cell gives that to them? Yep, this is where we start to see that we need to know the difference between the T helper cells, the Th1s versus the Th2s. Those Th1s and Th2s, they're both helpers, but CD4 represents all of the helpers. So anytime you're a helper, you're CD4 positive. Th1 helper cells signal the CD8 positive cytotoxic response. Remember, because Th1 is associated with the MHC1 type of response. So the Th2 is associated with more of that MHC2, which is the outside stuff. Think antibody when you think that stuff. In order to make antibody, you need signaling from Th2 T helper cells. All right, what are plasma cells? All right, so plasma cells is just our vocab term that is referring to B cells that have been activated and are secreting antibody now. So we activated our B cells. Remember, whenever you are naive B cell or T cell, it doesn't matter what kind of cell you are. When you haven't encountered anything, you're just now being activated by the presence of your antigen, your fidget spinner, whatever it is, that those B cells have to go first through proliferation. So that just means cloning themselves out. And then after they clone themselves out, the clones will differentiate into memory regulatory and effector cells. So again, that counts for B cells and any kind of T cells as well. The effector cells for B cells are our plasma cells. That's what they're called once they do that, and they make our antibody. Right. This could be more than one, so select all that are correct. Which of the following are functions of antibody? Lucky that we don't have to have multi-select on the exam. All right, so it's all of these, all of them are functions. There are 6 functions that we have to be aware of for antibody, and this is all of them, basically. Sometimes you'll see on some of the, I don't know if it's, there used to be another Kahoot that I had that like one of them did not belong. So just be aware of that sort of a situation. All righty, when antibody is produced, it starts as this, and then it will switch to this, preferentially, the more important ones that we're concerned about anyways. What do we start as? What do we switch to? Okay, so we always start as IgM. That's that weird pentamer snowflake looking guy that has like sort of general, quick and easy, setup. But as we are maturing, our B cells will switch over to IgG. That's our workhorse antibody. It is, a monomer. It's a single secreted, antibody unit. So it has more function in those 6 antibody functions that we were talking about. It's also going to be produced the most. 80% of your antibody response will be IgG once you switch over to IgG. And that is also the one that is going to have memory associated with it. So IgG is the goal. If you were seeing a parasite, you would see IgE being produced. You would switch to that, yes. But all of them are always going to have some aspect of IgG. And that's the one that we're more concerned about. All right, last question. Getting the chickenpox and developing resistance is known as what? You got the chickenpox, you actually got sick with it, and now you are resistant. Okay, so this is a natural exposure that we're talking about. So you're actually getting sick from it. So that would be natural as opposed to artificial, where we're introducing it medically speaking, like with a vaccine or something. And then active is meaning that you're actually producing that whole immune response that we've been learning about in chapter 16, making true memory from it and having your own antibodies that you're producing. So as opposed to passive, where they're being provided to you and it doesn't last. All right, so look at our little podium and then we'll get over to the lecture. Okay. All right, so chapter 17, if we don't have a very good understanding of chapter 16, this one could be a little bit rough. It's going to involve a lot of knowledge about antibodies and like which antibodies are produced for what situations and things like that. And if we aren't sure about which cells make antibodies or what T cells do and things like that, yeah, it could be a little tricky, but outside of that, this chapter is just pretty much reprise of what we should already know. So just applying it. So this whole chapter is dealing with immunopathology, and that's a term that we need to be aware of. It means we're studying basically the disease state associated with your immune system doing things that we don't really want it to do, whether that's allergies or, reacting against, transplant tissue or even against self, like actual self tissue. So all of those things. So we're talking about hypersensitivity, autoimmunity for our overreactive states. We also, though, have to look at the other side of the coin, which is our underreactivity or hyposensitivities. So we'll be splitting this chapter essentially up into two main categories, the hypersensitivities and the hyposensitivities. And most of it's on the hyper. There's 4 types of hyper, type 1, 2, 3, and 4. Easy enough, right? So this kind of splits it up, little infographic looking at these. The top is the hypo, which we'll get to in the end of the chapter, but that can be primary or secondary. Primary is going to be stuff that you have in your genetics. You're born with these problems. Secondary means you got it after you were born. So you get HIV and develop AIDS, or you have cancer that's affecting your lymphatic system, or you're being treated with chemotherapy or radiation that's destroying your immune system, that sort of stuff. And then we have hypersensitivities, type 1, 2, 3, and 4. 1 will be your allergies and anaphylaxis. Then type 2 will be antibody-mediated attacking of cells. Typically, we're talking about blood cells in that one. Type 3 is talking about immune complexes. And we have one in particular we're going to give as an example in this chapter. But immune complexes, it's just like what we're talking about with antibody, with agglutination and stuff like that. Antibody binds to things, and it can create these little clumps of things. We call those immune complexes, and they can cause some problems in our body. We'll talk about those when we get to type 3. And then type 4, everything from 1, 2, and 3 all has to do somehow with antibody function. Type 4, though, is cell mediated. So that means if you guys hear cell mediated immunity, that's always your T cells. The ones that are actually like the cells doing the work, not the antibody. So we'll get into what that's about as well. So hypersensitivities, we're talking about things that can trigger your response, whether you are dealing with exogenous or endogenous responses. So exogenous, of course, that's going to be anything outside of the body, and endogenous, endo, inside, stuff that's inside. So that could be like reacting to self, right? But outside is pretty obvious. If you're reacting to cat dander, that's outside, that's not self. So yeah, let me get a different pen. Okay. Alrighty, so exogenous and endogenous, right? So we're going to get into these 4 different types, and I've given a little bit of a summary here about what we're going to get into. Type 1, allergy and anaphylaxis, is going to be associated with IgE. So that's specifically that antibody, normally associated with parasitic infections. And we'll talk about how that comes to be. But type 2 is dealing with IgG and IgM, our typical antibody response. We are seeing foreign as foreign, except that it has to do with markers on blood cells, typically. Type 3, we're dealing with immune complex formation, and typically that is going to be IgM and IgG. It can be IgA as well, your mucosal associated. It really doesn't matter. It's going to be antibody associating with antigen. And like I said, those will bind together and stay kind of in your bloodstream. They can get stuck in little nooks and crannies, especially in your capillaries, in very thin capillaries, in your joints and places of stricture in your body. And then your body will see that as, oh, antibodies here, complement now has to happen, or neutrophils will come and eat up these things that are going on and whatever, and cause damage to the tissue in the area. So if I'm telling you there's going to be damage in these like small capillary areas or in these joints because of antibody antigen getting stuck there, that should automatically have you guys thinking about, when we're talking about your immune system going wrong, lupus and rheumatoid arthritis, because both of those are directly related to that immune complex stuff. Getting stuck in those capillaries, like in the face, you get the butterfly rash with, lupus. In rheumatoid arthritis, in your joints. So those are going to set up for that. And then type 4 are cell mediated. We also call it delayed type hypersensitivity. In your body, when you have memory B cells, your plasma cells that became, essentially the memory leftover, they can just start cranking out antibody right away. However, your cell-mediated
stuff, your T cell related stuff, when they have memory cells, they have to proliferate again. They don't just keep all of their arsenal at the ready. So they have the memory ones that can just go through proliferation. They don't have to go through all the signaling, but it takes 24 to 48 hours for those cells to reproliferate and start having their cell mediated responses. So that's why that will be delayed. And you'll see what I mean when we get to this and we start talking about the delayed type. But it'll make more sense when I give you the examples. But this is a good little table that kind of summarizes the types, how they're mediated, what mechanisms are involved, and how it leads to these pathologies. And some examples on the far right are over there as well. So good one for coming back to study at. So type 1 is what we're going to start with, of course. That's going to be our allergies and allergy-related type responses. This is all going to be mediated by the inflammatory response in conjunction with having that IgE antibody being present to whatever your allergen is. So an allergen is anything that makes you have this type of reaction, this IgE allergic response leading to inflammation and all this. Anything that triggers that for you, but it doesn't in other people. Like I am allergic to cats. Probably not everybody in here is allergic to cats. So that's an allergen. And it's not necessarily something that we see as, necessary pathogenic response, right? It's just weird, random environmental situation. So that's an allergen. These type 1 allergies are immediate onset. I go into someone's house, they have a cat, even if they clean up, I swear, like, I don't know, it's like even some tiny little molecule of it. My eyes will start itching and my throat will start itching and all of that within minutes of me entering that house. And we kind of know how this works, right? Most of us are familiar with this. Most of the time as well, if you get bitten by a mosquito, the enzymes and stuff that are in their saliva that help, make it so when you're getting bitten by a mosquito, right, you don't really feel it. Sometimes you see the mosquito on you and you're like, ew, yuck, and you swat it off or whatever. But when you're getting bitten, you don't feel it a lot because they have like these sort of numbing agents in their saliva, like whenever they're going to bite you, then they have the tiny little proboscis and all of this. But your allergic response, the whole reason you get the raised itchy bump is allergies, because you're allergic to the saliva, basically the saliva, right, that is in the bite from the mosquito. So that happens usually within minutes. Like you usually know before you go to bed that night that you had mosquitoes biting you because it's itchy. So it's a building effect. That first initial thing will happen. It'll start off immediately and then it'll build in response as it sort of cascades out of control. And that's allergies. It's not only the stuff that we think of as obvious, like being allergic to cats or hay fever or food allergies. So these are always associated with specific antigens. So like cat, it's actually whenever you guys know anything about like cat allergies, you're allergic to there's something in their saliva. And in their saliva, it's not the dander itself, typically, it's the saliva of the cat. And they lick themselves a lot to keep themselves clean because they're very clean animals. But yeah, it's that you're allergic to. So there's two types of allergies that you can have. They could be local or they can be systemic. So local ones are called atopic. So you ever heard of atopic dermatitis? Atopic dermatitis, you might have atopic dermatitis all over your body. And another term for atopic dermatitis is eczema. So you might have eczema anywhere on your body. There's specific areas that might be more prone to it than others, but it's just your skin that's involved. It's not your entire body. So there's eczema is an example of atopic dermatitis. It's localized. Whenever I have responses to cats, or if you have hay fever, or you're allergic to mold in the air, whatever it is, those allergies are associated with just your respiratory system, right? It's not your whole body that's necessarily getting engaged. With anaphylaxis, we have the allergic response throughout the entire body. And a lot of times that has to do with, because it gets into your bloodstream. So injectants are often the things that are associated with this. So bee stings. When you get stung with a bee and you're allergic to bees, it usually enters your bloodstream and it gets in your entire body and you go through anaphylaxis. You can go through anaphylaxis with things that aren't necessarily injectants, but those are the most common causes. Anything that's going to be in your actual bloodstream that you can be having issues with. So anaphylaxis is systemic, atopic is local. About half of the population is affected by airborne allergens. Probably most people have at least some kind of allergy to something, but airborne is the most common. So about half the US population has that. And it's partially related to genetics, but not entirely. We think that there has something to do with how, like, if you are raised around these things when you're very young, your body can train you to essentially see it as not a threat. So that's the ideal situation, except we're going to get into it here in a second, but we're not seeing the things that we used to see whenever we were, people that lived in, I say the wild, but you know what I'm saying, like back in the day of humankind, whenever we were first having our very first immune systems developing. So, yes, so the chance of a child getting that allergy is 25% if one of the parents is affected, and 50% if the grandparents and the siblings are also affected. So you're still not 100% chance, even if you have multiple family members around you that are allergic. For example, I'm allergic to cats. My dad is allergic to cats, and my mom is allergic to cats. My sister is not. She has a cat, and she's fine. So it's just about exposure during childhood as well as genetics. So this comes to that hygiene hypothesis. There are a lot of layers to the hygiene hypothesis, but the biggest message for it is our immune system needs to be trained by interactions with our environment while we are developing in our younger years. That's when your immune system is going through all of that training to tell you what is self and what is non-self and what is a threat and what isn't. Because, for example, the bacteria that are in your gut right now are non-self, right? And they should be seen as bacteria and recognized as such. But your body has to learn that they're not a threat. So stuff like that happens very early on in our childhood, age 2, around there. And so if you grow up on a farm, you're actually way less likely to have allergies than somebody who grows up in a metropolitan area. Additionally, if you're delivered by cesarean section, you're exposed to less microbes in the vaginal canal and microbes that are associated with stool. And so people who are delivered by cesarean are actually more likely to have allergies than people who weren't, because of that, being exposed to those different microbes. Pretty interesting stuff. The whole concept is that because we live in this industrialized world where we're concerned about hygiene and washing our hands, yes, you're fine. Yeah. So asthma and eczema are both atopic allergies. So if you are allergic to something, asthma is going to be like an inhalant version of the allergy. So that's going to be a local to the respiratory. And eczema is a skin-related allergy. And they're not necessarily triggered by the same things, but they are allergy. Yes, atopic. Mm-hmm. Yes. Yes. It's true. It's true in the sense that, yeah, some of the same allergens can trigger responses in different parts of the body as well. But we do have to look at them still as like skin versus respiratory, because, you're not always going to trigger one when you're having the reaction to the other one. But yeah, if you're having, the likelihood of being allergic to something on your skin and then on respiratory, because you can imagine that there are allergens that can be in both categories. So yeah, I mean, some of it crosses over. Unfortunately, that's just how it goes. But yeah, if you're predisposed to having those allergies, then that can absolutely be the case. And like we were saying, it doesn't have to necessarily be hereditary. You may have situations in your, life. Yes.
Okay, this might be a
No.
Also, eczema has to do with like the skin tone, because I have one kid that's darker than all of us.
Mhm.
He got his dad's tone, and he has eczema like so bad.
Mhm.
And, like my niece and stuff, nephews that are darker tone have eczema really bad.
Mhm.
But like me, super white, and my other kids, they're white, like super white, nose white.
Yeah.
They don't have eczema at all.
So I'm not sure exactly how the genes are going to tie in with that sort of stuff, but you might be surprised to see how things like that you would otherwise see as unrelated, like skin color or whatever, the genes that are associated with having darker skin color, or the genes that come associated with like backgrounds that are associated with having those darker skin tones, can predispose you to having the genes that could lead to having eczema or something like that. So, and that stuff gets really complicated as far as going back to heredity of mankind in general. But yeah, yes, because I mean, if we're talking about areas where, people eventually, like if we're talking about tropic areas, right? sub-Saharan Africa and in India and all those areas in that tropical areas where we have darker skin tone people because of you need the melanin to protect you from the UV rays and all that. They're also adapted to more parasitic infections because there are more parasitic infections in those areas. So they have a stronger background of having to deal with parasitic infections than people in like Scandinavia and areas like that, where we have the lighter skin colors and people were adapted to like colder environments where you don't have as many parasitic infections. So the IgE response in people with darker complexions will be stronger innately than lighter skinned people. So you can imagine that those things could relate to having certain predispositions to certain kinds of allergies, right? But it's way more complicated than that, unfortunately, because with intermingling of all the races and genetic information exchange and all this. But that's an astute observation, I will say that, because relating back to that concept of having to live in your environment and deal with your environmental factors and the factors of what people in the tropics deal with as opposed to in colder environments. Makes sense, right? When you think about it that way. I mean, it's stuff we don't normally weigh out here in the modern world, but it's the whole reason why our immune system has adapted the way that it has. So yeah, good questions, guys. All right, so here we have our categories of our allergens. These are obvious. And don't overthink them if we have questions about them on the test. If I ask you, is this thing an inhalant or something, whatever. If you inhale it, it can fall into the inhalant category and etc. So inhalants might be pollen, dust, and dander and things like this. It says insect parts. If you have cockroaches in your building or wherever where you work or live, their particles and their stool and stuff that they can leave behind, you can be allergic to those things, as well as dust mites. Those are everywhere. And dust mites themselves and their parts and their stool and everything, you can be allergic to that. It's actually extremely common to be allergic to dust mites. So that's insect parts, but you can inhale those, but you can also get them on your skin too. So that would be contactants, things you contact. That also includes things like latex, certain dyes, drugs, perfumes, and things like that. Those can all be like contactants. Now we have ingestants. These are things you would probably eat or swallow, including drugs. So drugs can be either in the ingestants or the injectants, because you can inject the drugs as well. And injectants is going to be anything that literally gets injected into your body or bloodstream, usually by a syringe, but it could also be like insects stinging you. But those are usually the only ones that we see in nature that would be happening as an injectant. It would be some sort of insect stinging. So, but yeah, there's our categories. If I asked you which category something falls into, just be aware of that. So we're going to walk through our type 1 allergic response. First of all, and here number 1, we have our sensitizing dose. We're talking about the IgE response, right? When you see an antigen, the first antibody that you make is IgM. So in order to get IgE, you have to have seen the thing first, right? And then switched to IgG and whatever else. So in this case, IgE, because your body is seeing it as a parasite, essentially. It doesn't know better. It's not getting any signals to tell it otherwise. So it's going to make IgE preferentially against pet dander, okay? So you see your pet dander, it gets into the body, and you have your B cell pick it up, it goes and gets stimulated by its helper cell, and now we're making antibody and eventually IgE, right? The very first time you see something, you might not have a reaction. The very first time you're stung by a bee, excuse me, you may not have a reaction, right? You just get stung by a bee and it's like getting stung by a bee and whatever. Everybody has that. It hurts and it sucks, but like that's it, right? But after your body has seen it and had the opportunity to make IgE against it, the next time that you get stung by a bee, you could have anaphylactic shock and die, which is exactly how we see it in like My Girl or whatever, which is like, I feel like the typical, example of, if you guys haven't seen it. It makes me feel old when I talk about it, and many people don't know what movie I'm talking about, but it's a really good movie. So anyways, you see these things the first time and you may not have a reaction. So you can go out and see something like a bee sting the first time and go around telling people, yeah, I'm not allergic to bees. I got stung by a bee this time and it was fine, whatever, I'm not allergic. But the second time you get stung, it might just be your second time. The first time was just your sensitizing dose. So we were made sensitive to it that first time. All right, and that's going to become really important in our type 2 response when we start talking about hemolytic disease of the newborn as well. Okay, so anyway, so we have our sensitizing dose. We start making IgE. IgE, so mast cells, which we learned about in chapter 15 as one of our granulocytes. Mast cells, one of our granulocytes, they will like pick up IgE from the bloodstream and put it on their surface like a receptor. So it's like interchangeable receptor, if you will. They don't make the receptor, but they have like little parts on their surface to hang on to those FC or those constant regions of those IgEs, specifically IgE, okay? And so they will hold on to IgE and they'll just exist like that for decades, just holding on to it like that. And anytime that those mast cells that have IgE, I really clutch too hard onto my pen sometimes. All right, so if this is your mast plus IgE, wearing it like a little receptor. And then the second time you see that bee venom or that pet dander or whatever it is, those mast cells primed with that IgE on their surface, that IgE sees the pet dander, it binds onto it, and that causes your mast cell to release its granules, its contents. And these are cytokines, like we've been learning about. But most importantly, one of those cytokines being histamine. So now we're getting into understanding how this is going to tie into what we understand about allergies. So they're releasing histamine, which is why antihistamines work so well for us when we take them. So that's really all that's happening. It's a nice, pretty picture with a lot of complicated stuff on it. But really all it is you saw this thing, your body perceived it as a parasitic type of infection. IgE gets stuck on a mast cell, and when it sees it again, it releases histamine. That's allergic response, okay? So the second time that you see that allergen, you already have these mast cells with IgE on them. And then every time you see it after that, again, mast cells with IgE on them, gonna pick it up and react to it. We already know though, and this is gonna come up in a minute, we already know that IgG should be the number one molecule made in response to an infection. For whatever reason, we got signals that IgE should be the number one in that response. So that we can use that knowledge later on to flip the whole thing on its end. So we will in a minute. But so IgE and mast cells are doing their thing to create these responses. Okay, so we have hay fever and asthma being sort of our respiratory level of our response, our atopic responses, right? Hay fever is just another term for allergic rhinitis. You can have rhinitis, rhino, yes, we're talking about nose here, right? We think about rhinoplasties and things like that. Yes, that's your nose. So rhinitis, itis is always inflammation. No matter where you hear that itis on it, it always means you are having inflammation in that area. So we have inflammation in the nose, and it is allergic in nature. You can have rhinitis from having a cold, but that's not allergic, is it? That would be, reacting to the pathogen appropriately. So anyways, acute rhinitis would be a cold. So asthma is our another way of like in the actual lung tissue itself. Inside there, we have bronchoconstriction and stuff like that associated with this. This is atopic dermatitis. That's eczema. We kind of talked about this, but it's sensitization usually through, it's not even necessarily through contacting things on the skin. It's contacting other things, and then it is being expressed through the skin. So your skin is showing the rash and everything, but it's usually something that you're inhaling or ingesting that is causing that effect. Sometimes it is from skin contact. All right, next we have the food allergy stuff. This is obvious, things like being allergic to peanuts or shellfish or eggs or whatever. And usually it's getting in through the intestine and can lead to gastrointestinal symptoms, obvious things like vomiting and diarrhea and abdominal pain. But usually when we think of allergens being ingested, we can have manifestations of eczema, hives, asthma, even anaphylaxis, depending on what the thing is that we're ingesting. All right, we can have drug allergies. Like we said, you can have a rash, or you could have up to anaphylaxis from those drugs. We see this very commonly with things like the penicillins and the sulfas. And then we also have aspirin and salicylates. If you've ever heard of somebody having an issue with salicylates, it's aspirin and like Pepto-Bismol has that in it, and you can't use salicylic acid on your skin or whatever. And then we have opiates, and then the contrast dyes that are used in, says X-rays, but we're really talking about like, CAT scans and things, I guess. Right, so anaphylaxis is systemic, and it's often going to be the injectables that are having this issue. So bee stings naturally, and then injections of antibiotics and serum or whatever that you can have this anaphylactic shock. But you always have to have a sensitizing dose first, and then the second one, you'll have that response. So my mom had to have some sort of, I don't know what, some iodine test or whatever done. And she had like a mild reaction like the first time. And so my mom's like, yeah, no, I just had like, got a little hot and had this or that or the other the first time. And she tells her doctors that she's never had a problem with iodine before. And she mentioned this the next time that she went. They're like, hey, we're going to set you up with this and that test. And they're like, have you ever had any problems with this? And she's like, well, I got a little hot last time. They're like, oh yeah, no, like instant, like red flag. We're never giving you this again. She's like, oh, I just got a little hot. And they're like, that was the first time, honey. Like, what do you think happens the second time? It doesn't get better. Like, we're not doing that. You might be in a hospital when it happens, but you don't want to risk it, right? So that's why they'll be really careful about that. You can do skin testing. We guys, know about this. They're going to give you like little pokes with different things, and then look at your back or your arm or whatever it is to see where you get welts, and then measure like the size of them to see how allergic you are to them and all this to determine, that sort of stuff. Create maps of what you're allergic to if you're having these things. We can block the allergic response with anti-allergy medication. The idea is to get in between where you have IgE being produced and somewhere between when that mast cell is releasing the histamine. So somewhere in there, we can have all sorts of ways to deal with that. We have anti-inflammatory drugs that inhibit that whole inflammatory response. We have antihistamines that can prevent the histamine from binding to whatever organs it acts on. So we know how that works. You take Benadryl and something like that. There's all different kinds of histamines as well. Some of them cross the blood-brain barrier and some of them don't. If you take Benadryl and you get drowsy, guess what? Benadryl crosses your blood-brain barrier, and that's why you get drowsy. There's other ones that are antihistamines that don't cross the blood-brain barrier. Things like that are less likely to anyways, like Zyrtec or Allegra or something, are less likely to make you drowsy, but they're also less effective with that antihistamine response as well. And they're not as immediate, right? You usually have to take them over time. So that's why they're made the way that they are. All righty. Epinephrine. If you have anaphylactic responses to something, especially if you've already been sensitized and you've had a reaction to a bee sting or to a food or whatever. So I had a friend that I used to work with who had shellfish allergies, and she could even be in the room with somebody who was eating shellfish or smell it, and she knew that was enough for it to potentially trigger her allergic response. And for her, it presented as anaphylaxis. So it was a systemic response. So she could have anaphylactic shock from not even having to eat the shellfish. She could just be near it. And so she had to carry an EpiPen. So this is EpiPen. EpiPen has epinephrine in it. It helps reverse constriction of airways, which is what the life-threatening aspect is of anaphylaxis. Epinephrine is the same thing as adrenaline. We're just talking about delivering it as a shot as opposed to your body making it naturally. That's the only difference between the terms. So you don't need to worry about the difference. In this class, if I say epinephrine or adrenaline, they're the same thing, okay? Same exact functions. So they're just terminology for medicine. But yes, but it has a very short half-life, and you might need more than one dose when you're having a reaction. So if you only carry one EpiPen, which a lot of people only carry one EpiPen, and you're having a reaction, you're having a reaction, and you have to hit that EpiPen and plunge it and get that delivered to your bloodstream as soon as possible, you had better be heading to the ER at the same time. Because just because you gave yourself that EpiPen shot does not mean your reaction is over. You give your EpiPen shot, you start to be able to breathe better, but your body is only okay for as long as that epinephrine is in your body. Once it gets out, you could still be having the anaphylactic shock, and you might not have another EpiPen. So you need to be getting to the hospital. It is only going to buy you time. It's only for buying time. All right, desensitization. So this is what I was getting at as far as your IgG versus your IgE response. If you are having an IgE response to something, so let's say you're allergic to bee sting, or you're allergic to pet dander or whatever it is, and you're making IgE in response to that. You don't make a ton of IgE. You just don't. Like, that's just how your body responds to something. But it's very, very little IgE. And yeah, it's bound on your mast cells, but whatever. But imagine that I can expose you in small amounts with certain amounts of chemical triggers as well, along with it, to trigger your IgG response instead. So you're allergic to pet dander. Great. I'm going to give you little bits of pet dander along with chemicals that signal for IgG response instead. Now you're making IgG, and it's going to be in just hella heavy amounts, right? IgG can then overpower IgE response. It can bind with all your pet dander in your blood or wherever and bind it all away so that IgE never encounters it first, because it's faster, it's stronger, it's better. Get that the IgG instead, and it can overpower that IgE response. So that's how we can desensitize. So it depends on that IgG specificity. All right, so other things we can do to block our allergy attacks. Steroids shut down IgE production in general. I don't know if you guys know this, but they don't just shut down IgE production. They can shut down your entire immune response. So you don't want to take steroids long term. And any steroid creams like hydrocortisone, for example, really, really bad for you. Don't use them long term. I'm completely serious about this. Use your hydrocortisone creams for a couple of days, unless your doctor tells you otherwise, of course. But it can severely deplete the integrity of your skin and make it a lot thinner and make you more susceptible to infections because that barrier is not intact anymore. Yes.
My niece just recently, so she has eczema really bad, but she just bought the cortisone over the counter and was putting that on for years and years. Her skin started flaking off, so she went to a doctor and they're having to wean her off of it.
Mm-hmm.
But her like hands swelled up 10 times bigger than what's normal, and it went like all the way up her neck. And luckily, it stopped at her neck and didn't get up into her face. The reaction. But literally, it looks like her hands are so raw because the skin is just flaking off.
It's just completely destroys the integrity of your skin, and it's one of those things that you cannot keep long term. You're only really supposed to be using. It's sort of like Afrin. You guys know the rule with that, right? Only like 3 days and then stop. Like it's sort of like that, because your skin will become dependent on it being there to interact with it. And then when you stop using it, it causes all sorts of problems. So steroids in general are like that. We already know about steroids being bad for you. They can cause weight gain. They're going to deplete your ability to fight off any infections and all sorts of stuff. So whatever, steroids are steroids for temporary, and it'll fight any sorts of inflammation. Yes.
There's this thing, it's called the juice shot.
Mhm.
It's like a steroid. It's like dexamethasone and like B12. And I have friends that go and get it
Mhm.
like every couple months.
Yeah.
One has though, she has immune issues already, and she has like we've mentioned a couple of them, but she has like stomach issues and the rheumatoid arthritis. So she's like, I'm getting achy, I'm gonna go get it. I was like, you better immune up, take your zinc and your vitamin C, like you always get sick after.
Mhm.
So is it safe that she's continuing to go every so many months?
I mean,
She's not going
so
to like her doctor.
stuff like, right,
clinic.
like clinics, yes. So stuff like that, people are going because they want to reduce inflammation in their bodies, right? And it's great for like a temporary thing, but to rely on it long term is when, yes, it's really dangerous. So that's where it's the issue. Yeah, and it'll be fine. Like she'll probably feel better for a couple days after she'll get there, and then it'll get worse because her immune system got messed up from having that stuff. So it's great. One of those things, if you're like getting married and you get one of those shots, like, the day before you get married, great. I'm sure that's fine. But if people are getting it regularly, yeah, it's going to screw up how the immune system works. And our immune system works the way that it does for a reason. Yeah. There's better alternatives for long term for that stuff, as opposed to, especially if you're talking about steroids and stuff, but those are great for like immediate relief, sort of like with Afrin so it's not good for long term. Yeah. I mean, of course I would talk, if I was in that situation, talk to an actual doctor, and I'd go to an immunologist if that was me, if I was having those kinds of issues. But anyways, we have antihistamines that can block the effect of the histamine, even if it's being produced. We have being aware of the allergens and just avoiding the allergens. And then, of course, desensitization. being exposed to something and making IgG, so it blocks it out instead. So moving on to type 2 now, right? So that was type 1 is the allergies. Type 2, now we're having mostly talking about blood types here. So first of all, we need to understand about blood types. These are our ABO antigens. And there's 4 distinct blood types, A, B, AB, and O, okay? These are just markers that are on the surface of cells, and you can carry genes that are like combinations of these, okay? And the only genes that you have are A, B, and O, all right? If you have A or B, they are equally dominant. O is recessive, okay? So in order to have an O blood type, you have to have 2 O genes, an O from your mom and an O from your dad. That's the only way you can be an O. Turns out that the most common blood type in the world is O positive, interestingly enough. So it's not like that makes it rare, but it just is recessive. You do have to have 2 O's, but people can carry around the O's. If you have an A from one parent and an O from another parent, your blood type that you express is A, but you're carrying that O around. So now you can see how the O makes its way through the population. But anyways, so you get an A from one parent and an A from another, you're A. If you get an A from one parent and an O from another, you're A, because the A is dominant. Same thing with the B, right? If you get an A from one parent and a B from another parent, you're AB. They're both equally dominant. So they're both expressed. Make sense? So the A and the B equals, the O is recessive. And even beyond that, it's even, I'm gonna go down to this next slide down here just to show. Down here on the bottom, we have the type O. O means you have this group on here. Well, look, everybody has that group. So O is kind of like our base that everything builds off of. And then it's whether you have the A on there or the B on there, or you might have both of them. Like we see in this example here, we have AB, where we have both A and B on there. Cool. So that's our blood types and how that they're going to be expressed. We look here at the characteristics of them. If you are an A blood type, you automatically have anti-B antibodies. If you are a B blood type, you have anti-A. If you are an AB, you see both of those as self. So you don't have antibodies against A and you don't have antibodies against B because those are both friendly to you. So guess what? You'll have neither of those. So guess what kinds of bloods AB can get received? ABs can receive anything. They can receive A because they don't have anti-A. They can receive B because they don't have anti-B. They can receive O because everybody has O as their base. And of course, they can receive AB. That makes sense. So AB ends up being our universal recipient. They can receive anything. My sister, AB positive. I know, lucky, right? AB positive, it's a rarer blood type. You don't see as many. AB negative is the most rare, but AB positive is pretty rare too. You don't see a lot of them, but it's the best one to be if you're a patient because you can get literally any blood type at all. But then we have the O's. O's see A as foreign and they see B as foreign because they don't have either of those in their body. They're both weird to them. So they have anti-A and anti-B. So what kind of blood type can O's get? O, and that's it. So we talk all the time about how O negative is like the universal donor. O negative, it doesn't have A to it, so anybody can get it. Then if they're anti-A, they're safe. If they're anti-B, they're safe because we don't have B on it. Anybody can get O. We all have the O underneath our types, right? And the negative is talking about the RH factor, which we'll talk about in a second. But that's just whether you have the RH or don't have it. There's not a bunch of different kinds, it's whether you have it or not. So if you don't have it, that's the base for everybody. If you have it, not everybody does. So O negatives can only receive O negatives. O positives can receive O negative and O positive, but that's it. So that starts to make sense a little bit there when we're talking about that. So O negatives are our universal donors, but they are not the most common blood type. So if you are O negative and there's a mass casualty situation, there's some sort of war thing going on, maybe the city gets bombed and we have a whole bunch of people coming in to the hospitals that need blood transfusions. They don't have time necessarily to wait for everybody's blood type to come back from the blood bank to start transfusing people. So they reach for O negative first. they try to keep as much O negative as they can on the shelf. But what happens if you're O negative and you get there after everybody else has gotten the O negative, just to keep them alive till we figure out their blood type? Yeah, so it becomes an issue. So that's a huge problem. But anyways, you guys get this in our universal transfusions. If you get the wrong blood type transfused into your bloodstream, your body, like we said, if I'm A positive, right, and my dad's B positive, and if I got my dad's blood type put into my body, my complement cascade would be triggered by that classical pathway. I have anti-B antibodies in my blood. So my blood with my anti-B sees my dad's B positive blood and starts complement cascade. Those inflammatory response, the opsonization, and the membrane attack complex. So lysing, breaking open all of my dad's blood cells. That triggers your whole body to freak the fuck out, basically, because it's just like, why are we just destroying blood cells now? Is that what we're doing? Okay, great. So the destruction of your red blood cells, having to filter that through your spleen, and triggering this whole inflammatory response, your body goes into shock very quickly, and death can happen very quickly if you don't catch it early on. You start seeing jaundice pretty quickly as well, because you'll have liver failure associated with the release of all these toxins and things in your blood from those cells dying and that. So if you can get it early on and start giving treatment with like removing hemoglobin is what they say, like basically dialysis immediately when somebody has these reactions, you can save them, but it is extremely dangerous. If y'all think that OBI is perfect in their blood typing, or that your hospital is perfect in your blood typing, you're wrong. It's people that are doing a lot of these tests. Machines are involved in it, of course, but like usually there's hands-on with people. And I don't know if you've noticed, but people make mistakes sometimes. We can forgive them for that, generally speaking, but sometimes in these sorts of situations, it's life and death, and that these things happen. It's why if you donate your blood to OBI and they send it to their lab and somebody slaps the wrong label on a blood bag and sends it off to Integris, and Integris will cross-match it again when they get it. Every bag of blood that comes to Integris, they're going to cross-match it before they put it back into their inventory. And there's a reason for that. And that's because of human error. And it happens. They'll catch it sometimes that it got mislabeled. And oftentimes it'll be like not just one bag, but they didn't see a blood bag get through the system. And then the whole next line got mislabeled as a result. So it's crap like that. But that's why we have these checks and balances. I wish I could tell you that I don't have anything comforting to say, is basically what I'm trying to say here. It doesn't not happen often, of course, but that's why we have these checks and balances. So Rh factor, again, this is just whether you are positive or negative at the end of your A or B or AB or O, okay? This is called the rhesus factor, and you either have it or you don't. And if you don't have it, then you would see it, the rhesus factor, the positives, as foreign. It's just another one of those, okay? So this is where we're going to be getting into, in case you guys aren't aware, this is going to be ROGAM and what ROGAM does and why it's important. So we're going to talk about hemolytic disease of the newborn. What happens is if you are a mother who is Rh negative, all right, you've never seen Rh positive in your body before, and you have a baby, and you're the person that you made the baby with was a positive, let's say, and your baby is a positive now. You're carrying this positive baby, your body will see that baby's blood as foreign and create antibodies against it. It's specifically that rhesus factor. I bet the internet connection is unstable. I bet it is. All right. Have you been in this building? Okay. This, so the mom is going to see that Rh factor, her body anyways, is going to see that and make IgM and IgG antibodies. Specifically IgG is what we're concerned about, right? Because that's our fast responder in the next, after we've been sensitized. So IgG antibodies eventually going to get switched to carrying that baby. Now we don't see the Rh factor until later on in the pregnancy. So we don't start making that antibody until later on in the pregnancy. Additionally, it doesn't really become an issue until closer to birth, when we start having that severing of that placental barrier and connection, if you will. Okay, so it doesn't really become too much of an issue until later on in the pregnancy. You can carry your first Rh positive baby perfectly, no issues whatsoever, but your body will have seen that now and we're sensitized. So the second pregnancy is where this is an issue. So In the second pregnancy, if you're Rh negative and your second baby is Rh positive, you're going to attack with IgG full force onto that baby. Easily, that baby can die. This is still an issue today. If somebody didn't realize that their baby, that they were Rh negative and their baby previously was Rh positive, because somebody wasn't notifying somebody, or you moved to a different doctor and they were just going to keep track of it for you, or that doctor, didn't keep good notes about it, or whatever it is, for whatever reason, this happens still today in modern society. I usually have at least one student every semester tell me about somebody they knew that lost their baby because of this. This is still today. RhoGAM is given out like nobody's business nowadays. If you are Rh negative at all now, they will not even wait to say, like, did you have a baby previously? They'll just give it to you to be safe so that you don't reject that baby and you don't kill that baby in your womb. Imagine having a stillbirth after having a perfectly otherwise healthy pregnancy the whole time. And that's what happens with hemolytic disease of the newborn, when the mother's antibodies attack the baby and the baby dies because of the same exact thing that you would have if you were rejecting a blood transfusion, but it's happening inside a little baby. So that's hemolytic disease of the newborn. RhoGAM is an antibody that blocks that interaction. So it is another, antibody that we're using to block antibody interactions, but it works very effectively and very reliably. And that's why that's a thing. So, all right, so this was our questions. And since we got started late again, because of the frickin' computer thing, I'm just going to go through these ones with you guys again. So what type of antibody is involved in type 1 hypersensitivities? Type 1 is IgE. What is the difference between atopic versus anaphylactic reaction? Atopic is a local response. Anaphylactic is systemic, so over the whole body. What is the best treatment for anaphylaxis? Epinephrine, right? What blood types can type O negative receive? And that's going to be O negative. That's it. That's all of them. Would a B negative baby be at risk in an AB positive mother? No. So hemolytic disease of the newborn primarily deals with the Rh factor. Could you potentially have an issue if that mother was AB? So the AB positive mother, she doesn't have any anything in her. To her, A is self, B is self, plus is self. Anything lacking in that is never going to be a problem. So she could receive any blood type. So she can also see her baby's B negative as self. So no matter what blood type she was carrying, that AB positive mother can carry any kind of baby safely. She doesn't need RhoGAM. It's when the mother is the negative that the positive baby is at risk. Make sense? Okay. That question's on there for a reason. All right, so moving on to the immune complexes. Again, you got antibody in your blood and you got antigen in your blood from an infection or whatever. And we've got these things binding up and collecting. Most of the time we have big complexes forming. They get cleared out by your macrophages and stuff pretty easily. Little ones get filtered out pretty easily. But these medium-sized ones can get stuck in what we call the basement membrane of your endothelial cells. So the lining of your blood vessels, and especially in areas of stricture, like in joints and thin capillaries and things like that, which we see in a lot of areas of the body, especially the kidney and capillaries in the skin, the joints, all of these areas. So they'll build up there, and then we will have complement cascade, and we will have neutrophils getting called into that area because of the inflammation, and then we'll have damage of the tissues in those areas. Just the immune response. It thinks that it's doing something good for you, but it's actually just causing inflammation. All right, so that's our type 3. This is also IgG and IgM. It could be any of our antibodies for the most part, but it's typically IgG and IgM, just like our type 2. So type 1, IgE, type 2, IgG, IgM, type 3, IgG, IgM, right? It's just we were attacking the cells in type 2, and type 3, we have these complexes that are made that are getting stuck places. We usually need a lot of antigen associated with these in order to build up all of these complexes. It's not like we only need a little bit in order to react like we do with allergies. So we need these guys to build up more. So it takes a larger dose of antigen to cause this response. But once you have it, it can be an issue. So this is acute post-streptococcal glomerulonephritis. This is a word I can't say, but it's the kidney, okay? So glomerulonephritis. These are associated with strep infections. It's group A strep, which is like what you get with strep throat. Okay, it's Streptococcus pyogenes. Very common microbe in bodies in general, and that cause disease, and not just strep throat, but in a lot of other areas in the body. Anyways, you get antibodies to strep, and antigen associated with strep can bind with it and get stuck in parts of your body. And then we have this whole immune response going on there. One of the places that it gets stuck is in those very thin, important toxin exchanging areas of your kidneys where we're filtering out things, right? And they get stuck there. And then we have the immune response there. And that's where you get that glomerulonephritis, the itis being the inflammation in the kidney tissues. So they'll build up there and you'll get inflammation there. This can actually damage the kidney to the point of kidney failure if it gets bad enough and isn't dealt with or doesn't subside on its own soon enough. So this can be deadly. All right, so that's it. That's all we need to know about type 3. You could see though, and I mentioned earlier, but we're going to get into autoimmune in a second, that could happen with autoimmune responses as well. So type 4 hypersensitivities, these are our cell mediated. They're delayed because the T cells have to like repopulate first before they can react. It takes 24 to 48 hours. Tell me that you guys don't know. Most of you guys going into healthcare, working in hospitals, tell me that you don't already know about one of these type 4 hypersensitivities that you might not think of as being an allergic or health risk type of situation. The PPD tuberculin skin test. Why do you think they inject you and have you come back, 48 hours later? Because it's a T cell response. They have to give it time for your body to reactivate. And then if it reactivates and you get a bigger welt, that means that your body has seen tuberculin before. And so that's what they're looking for, to see if you've had a T cell response to tuberculin. T cells specifically, we're not as interested in antibody because tuberculosis bacteria live inside of your cells. So because they live inside, what's the more important response? That cytotoxic T cell, that MHC1 response, because they're inside. So that's what they're interested in and why it does that. So 2 to 3 days is usually when you start seeing a response. So it's like that 48 to 72 hour thing where they'll look at that. That's not the only one. That's one we're most probably familiar with as far as that goes. But there's also contact dermatitis. So this is different than atopic, right? This is contact dermatitis. We're talking about poison ivy and poison oak primarily, but it can also be certain perfumes and dyes and metals that can have this reaction. If I wear earrings that are not stainless steel or silver or gold, it's pretty much anything but those three. If I wear earrings that are that, then within 48 hours, I will have a rash on my ears, or rings as well. All my rings have to be sterling silver or gold, like even not very good with some of the other ones that I wear, but stainless steel even. So but it doesn't happen until a couple days after I wear that jewelry. That's contact dermatitis. And you'll see the difference too. If you have something that you're allergic to as far as like immediate allergy, and you get some hives or whatever, that's a completely different reaction than what you see with like poison ivy, where you get the weeping and the oozing and it's gross. And like your cells are actually getting damaged because those cytotoxic T cells are killing your cells thinking that they're infected with something. So that's what's actually happening there. So you get a dendritic cell in your skin that sees poison ivy and brings that to your, on MHC2, finds it outside first on MHC2 and activates the normal response with the T helper cells. One of those T helper cells that gets activated, Th1 helper cells that activate the CD8 positive cytotoxic T cells that go out and kill all of these cells that have that chemical on it because it sees it as inside, bad, kill these cells type of stuff. So you get that inflammatory response, you get the weeping and all of that. So that's what's happening. This is also what happens with graft rejection. My body would see your kidney with its MHC1s just chilling. It's not holding up anything saying, help me, no red flag here. It's just chilling. But it sees your MHC molecules, your MHC1 molecules as saying, help, there's something inside me, please kill me, because it looks slightly different. Still looks like MHC1 to me, but it looks like MHC1 calling for help. And so I will just kill your cells. That's what I'll do because it looks weird. whatever. And that's what happens with graft rejection. Okay. So it's type 4. Graft rejection is a type 4 hypersensitivity. So we have two versions of this, host versus graft, which is like what we're usually thinking of. I'm attacking the graft. So it's host versus the graft. Okay. Put your kidney in me. I see your MHCs as foreign. There's another version now called graft versus the host. If you get a bone marrow transplant, let's say I get your bone marrow into me, your lymphocytes in your bone marrow, your B and T cells that are coming from your bone marrow out into my body that I got, transfused into my body, they're coming out and seeing my cells as like that. They're seeing it as those MHC molecules look like they're calling for help. We need to just start killing everything in this person's body. So that is when the graft is attacking the host. So that's less common, of course, but it is one other possibility. So it can go either way. It just depends on what kind of graft you're getting. There are different kinds of grafts that you can receive. Some are safer than others. You're less likely to reject them than others. The autograft is the graft from self. So you get a burn, and I'm going to give you a tissue graft from your back to cover that. That's an autograft. Isografts are from twins, clearly going to be genetically identical. That's great. Allografts are from other people. So you're not genetically related to these people, or you're not closely enough genetically related. And then xenografts are from typically animals. So we're talking about heart valves from pigs, for example. Okay. You can get these from living donors or recently deceased or even fetal tissues. You can get deceased donor tissue, like from truly deceased people, like their cornea tissue and things like that. They're actually dead. They're not brain dead and on life support. Most of your organs, your hearts and your lungs are definitely going to come from brain dead. They have to be on life support, keeping that organ actively alive in order for it to be properly transported and everything. But kidneys can come from actual living donors. We know we have 2 kidneys. You could potentially lose one and give it to a loved one. But you can also get it from those brain dead donors otherwise. If you're dead, you cannot give a heart or a liver or a kidney or any of that. If you're dead, not happening. There's only certain tissues. And then we, of course, have the fetal tissues. Let's just talk about stem cells from certain parts of fetal tissues, not commonly used compared to the other ones. For autoimmunity, we're talking about hypersensitivity to self, and hypersensitivity can happen as a result of responding to infections or parts of infectious particles. So like antigens associated with things, you see it in the vaccine form, but now that you've seen this thing in the vaccine form and create the antibodies to that, it looks similar to self, and now we're also triggering a self response. So that's possible. Autoimmune diseases are not uncommon. And here is a chart that is showing us some common, we'll say common, relatively speaking, right? Autoimmune diseases and the types of hypersensitivities that they are and how they're affected in their body or just locally or whatever. Lupus is being type 3. Rheumatoid, we have aspects of 2, 3, and 4. So you don't just always have just one type of hypersensitivity going on. So I'd be aware that all of these are autoimmune diseases. We've got lupus, rheumatoid, ankylosing spondylitis, Graves, which is the thyroid, myasthenia gravis is the muscle. Type 1 diabetes, not type 2, but type 1 is an actual autoimmune disease to the pancreas. And then multiple sclerosis is attacking the myelin sheath on nerves. These are all autoimmune diseases. This can come, like I said, molecular mimicry, when markers on pathogens look like your cells. We also, that seems to be the case with rheumatic fever. When you have like strep and reactive strep, it creates antibodies that recognize things that look like you, and it just happens to cross over. We can also have true infection. We think that type 1 diabetes can be triggered, and MS can be triggered by measles. There's a link there. We don't know entirely what it is, or if you need true measles infection versus the vaccine, we're still unclear on that, but they seem to be linked. And then viruses, if you're infected with certain viruses, it can change the surface of your cells. So they look different. And so that can cause that as well. You can also cause changes in your microbiome from certain kinds of infections or exposures to drugs or whatever it is. And then that shift in your microbiome can cause eventual leading to autoimmune disease as well. So moving on to the immunodeficiencies. Oh, geez. We're almost done, I promise. The immunodeficiencies, we have the primary and the secondary Remember, primary is going to be the ones that are present at birth. You have genetic defects. And secondary is going to be acquired after birth. You have some sort of disease that you get or chemical you're exposed to that causes that. So this is just showing all the different places in the immune development that you can have these genetic defects affecting you. You don't need to know every single one of these guys, but if you're interested, there's a thing there about it. You can have deficiencies in B cell development, leads to inability to make certain antibodies. But more severe ones are usually going to be the T cell related ones because you need your helper cells to activate pretty much every response that you have. So if you're having issues with your T helper cells, they're going to affect every aspect of your entire adaptive immune response, not just the T cells, but T cells and the B cells. So you'll see more opportunistic infections, wasting, as well as cancers associated with that. DeGeorge syndrome is one of these where we have abnormal development of our T cells as a result of issues with the thymus. So that can be causing infections that can be fatal in some children. But of course, we've mentioned previously, severe combined immunodeficiencies or SCID. There's different versions of these and some of them are worse than others. But yeah, this is boy in the bubble disease. You don't have any B or T cells at all, period. You just can't fight infections. You have absolutely no memory whatsoever as far as your immune response goes anyways. But yeah, so you usually know within days after birth if a child has this. I have a student in my Tuesday morning section that works at OU Children's, and they deal with serious issues and like little babies, and they've had 2 babies in like in a month that were both diagnosed with SCID. And one of them was essentially going to be boy in the bubble version of it, which is like the worst one that you can have. So some of them can be treated, but some of them can't. Secondary is acquired. Like I said, it's usually from infection, like with HIV or with certain metabolic diseases. Chemotherapy and radiation also take out your immune cells just in general. So you can have that happening from that as well. AIDS is the obvious one. So you have HIV that you would be getting, and that leads to depletion of your T helper cells, and that can result in opportunistic infections and cancer development. Cancer itself, you can have affecting your lymphatic tissues and leading to your immune system not being able to function as a result of that. So our last questions, these were our last questions of this chapter. I'm just going to leave them here. I'm not going to go over these ones. If you guys want to take pictures for study purposes, you can. I'm going to leave it up here just for a second, but that's the end of this chapter. If you guys want to get your lab coats on and ready, we're going to get cranking right into the lab stuff. Yes.
So on the study sheet, I don't see anything about like the semi. Hold on. It doesn't mention like semi-synthetic and synthetic drugs and stuff on the study sheet, so I'm assuming I don't need to really worry about that.
If it's not on there, then I know.
If it's not on the study sheet, then no. Okay, I won't write those down then.
Yep.
I'll shorten up my notes a lot going off the actual study sheet instead of writing down literally everything.
Yeah. That's what I say, man. You're supposed to just go by that study sheet. There's other stuff on here that's supplemental to help understanding, but it's not necessarily.
I'm a little bit behind on notes. I'm like a chapter behind. No, 2 chapters. Yeah, 2 chapters.